The searing memories in my life is being in a children's hospital in Boston with my son, who had lost his leg to cancer. And he was under a regime that was going to take 3 days of treatment every 3 weeks for 2 years in order to be able to be in this process or this system, this treatment that offered the best opportunity. And it was being paid for, since it was an experimental, by NIH. And they paid for probably the first 4 months that I was in that particular regime. And after that, it demonstrated some success, and they stopped the payments. But for all the other families, they didn't have the kind of health insurance that had. It was $3,000 for every family every 3 weeks. And I listened to these families who's had their children had the same kind of affliction that my child had. And they said, look, we've sold our house. We have the $30,000. We have $20,000. We're able to afford it for 3 months, for 4 months, for 5 months. What kind of chance does my child have to be able to survive? I knew that my child was going to have the best because I had the health insurance of the United States Senate. And I knew that no one, no parent in that hospital had the kind of coverage that I had. That kind of choice for any parent in this country is absolutely unacceptable and wrong, my friends. And I can tell you this. When every member of the United States Senate comes in and signs into the United States Senate, they signed a little card in 2 places. And one is their signature for their salary, and the other is for their health insurance. Their health insurance. Now, Senator Brown of Ohio, to his credit, will not accept it until the people of Ohio get it. Every other member of the United States Senate, has accepted it. And for the 15 times that I have fought on the floor of the United States Senate that we ought to have universal comprehensive coverage, and to listen to those voices on the other side that have universal and comprehensive coverage and say, no, it is not time. We can't afford it. It's the wrong bill at the wrong time. My friends, if that health insurance is good enough for the members of the Congress of the United States and good enough for the President of the United States, it's good enough for everybody in Montgomery County, everyone in Pennsylvania, and everyone across this country.
Welcome back to Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're proud to be a community partner with Forward Radio, WFMP LP 1065. Please join our community, especially this Thursday, September the 17th, for Give for Good Louisville Day, the biggest fundraiser day for Forward Radio. Forward Radio receives additional funding from the Louisville Community Foundation for donations received for Give for Good Day. You can go to forwardradio.org and click on the box on the homepage marked Support Forward Radio September 17th, Give for Good. It's easy, and please give what you can. No donation is too small. Forward Radio is a real gem, and let's keep her going. Forwardradio.org this Thursday, Give for Good. And let me say, the views and opinions expressed here on Forward Radio are those of the speakers and not the station. And speaking of gems, joining me again in the studio are Dr. Mike Flynn and Dr. Gene Shively, as they have been here in the studio for this year's Single Payer Radio. And Speaking of Give for Good, our guests today have been giving Louisville good for decades. Dr. Garrett Adams, past national president of Physicians for a National Health Program, and our state PNHP chapter, point person, and Kay Tillow, chairperson of Kentuckians for Single Payer Healthcare, who brings decades of experience fighting for civil rights, worker rights, and healthcare justice. I attended a compelling presentation on single payer given by Dr. Adams at an America 2000 meeting around, I think it was 2004, Dr. Adams, and the rest is history. You sold me on it that day, and I thought, why aren't we doing this? So Dr. Adams, Kay, welcome to Single Payer Radio, and we'll let you guys start off by saying a few words, and then Dr. Flynn and Dr. Shively will chime in with their questions.
All right. Thank you so much, Mark. I remember that day. I remember that night. I remember where we were, and those were the days. It's taken us a long time to get it done, Mark. Just keep hammering away. But thank you for your work with Forward Radio and for the opportunity to be with you all. And thanks to Mike and Jean for wonderful programs. I've really enjoyed what I've heard so far, and I appreciate the opportunity to be with you and to be on this with one of the smartest people about healthcare policy in the United States. And it's a real pleasure and a privilege to work with Kay. I learn a lot every time I work with Kay.
Wow. Thank you, Garrett. You are much too kind with that. I'm just thrilled that we have Single Payer Radio up on the air with a weekly program. And I thank Mike and Jean and Mark for making that happen. And it's been a joy to work on single payer since the founding of our organization in 2004. And I do believe that the work that we do makes a difference and that we are closer because we are building a national movement and understanding that will have to be the pressure that finally gets the country to go where the rest of the industrialized nations have gone long before us. And we have to remove the private for-profit industry from our healthcare system. They are a contradiction because they sit in the decision-making position, the insurance company, and their interest is the opposite of the patient. Their profits are increased when they deny care. So it shouldn't be that way, and that's what we're working to change. And I do believe that all of us together are going to be able to do that.
All right, let me begin with the usual disclaimer that any views that I express are my personal views and do not represent the views of the Department of Surgery or of the University of Louisville.
I would like to say that my views are my own and do not represent the views of Taylor Regional Hospital nor the Department of Surgery at the University of Louisville. Kay, you brought up some interesting questions, and I got a phone call from an orthopedic surgeon who I grew up with in Campbellsville, and he'd been listening to some of our podcasts, and one of the things he was interested in, since he had just retired from the VA, is who's going to be in control of this Medicare for All? Is it going to be the bureaucrats or is it going to be the doctors?
That's the question?
Who's going to be in control? The doctors taking care of patients or the bureaucrats?
Oh, the doctors have to be in control of making the decisions about patient care. It shouldn't be any other way.
Well, you also brought up about for-profit insurance companies and also for-profit hospitals. What would happen to these insurance companies? For example, in Louisville, Humana hires about 12,000 people. What would happen to these companies, and what would about the economic impact of laying off 12,000 people?
Well, the legislation that would make single-payer health care happen will provide for transition for the workers within that industry, because they will need jobs, and it will make provisions for them to have a transition to a better job. You know, it can't be much fun sitting in an office and turning down claims. So people will have an opportunity to do better work. And that's what will happen. We have to make arrangements through the legislation to assure that the people who work in that industry are provided for with alternative jobs. And Humana can make money some other way, not exploiting patients.
Garrett, back in December of 2019, I did a surgical grand rounds on healthcare in America, and in a very abbreviated way, we talked about a lot of the issues that Gene and I and Mark have talked about in these programs. And at the end, one of the faculty members made a comment, which I'd like to aim at you and let you respond to it. And the comment was that not only the physicians, but a lot of just the man in the street really don't understand when you say single payer or Medicare for all. They don't understand what it is. Some people think it's going to be an entire rearrangement of the healthcare system like they've got in Britain. So maybe you could take a few minutes and explain to our listeners, whoever they are, exactly what single payer would be, assuming we get to the point where we can actually have this in the country.
Great question. I have an answer, and I'll give you the answer that has been prepared in the past just for that question. The question is, what exactly is single payer? Physicians' proposal for a national health plan, which I first read in my when I was the director of communicable diseases at the Louisville Jefferson County Health Department in 2003. I still remember the time and the day when I read this in JAMA, and I'm going to paraphrase that in just a few minutes, but initially, the physician's proposal for a national health plan was the answer to single payer, and the proposal was put into language in a bill in Congress that Congressman John Conyers put forward, House Resolution 676, which was the roadmap to single payer. And the message is that single payer replaces the health insurance industry. I'll repeat that. Single payer replaces the health insurance industry and substitutes cost-efficient central planning for market-based healthcare profiteering. The term single payer means that one fund, administered by a nonprofit government agency accountable to the public, would make payment for all medical services, period. So that's the short answer. And I want to just go over, because we refer to the physician's proposal frequently, what is the physician's proposal? And I've taken the points that are in the proposal and sort of shorten them a little bit so that we could just kind of go down through the list, because some of these other questions that you and Jean have posed to Kay and I can be answered in the proposal itself, which was restated since 2003. It was restated in 2018 in the American Journal of Public Health. Number one, removes all financial barriers to medical care. Saves enough on administrative overhead to provide comprehensive coverage to the uninsured and to upgrade coverage for everyone else. That's the underinsured, thus requiring no increase in total health spending. Puts in place effective mechanisms to control costs, lowering the rate of medical inflation, and making the health system sustainable for future generations. Restores free choice of clinician and hospital to all Americans. Every resident of the United States, including all immigrants, is covered for all necessary medical care. A national health program card entitles patients to care at any hospital or doctor's office. Provides coverage for outpatient and inpatient medical care, as well as rehabilitation, mental care and long-term care, dental services, and prescription drugs. Improves on traditional Medicare's benefits and expands coverage to all Americans. Eliminates premiums, co-pays, deductibles, and co-insurance. Is federally financed like Medicare and administered by federal, state, and regional boards. 676 emphasized the physician component and physician leadership in all of those boards. Private insurance that duplicates the national health coverage is prohibited. The initial increase in government costs is fully offset by savings in premiums and out-of-pocket costs. Hospitals and other health facilities will be on a budget. Most remain privately owned and operated, receiving an annual global lump sum budget from the national program to cover all operating costs. Physicians are paid based on simple fee schedule covering all patients or by salary. Medications are purchased wholesale. It's paid for by combining current government health spending into a single fund with modest new progressive taxes fully offset by reductions in premiums and out-of-pocket spending. That is the physician's proposal, which is the basically the Constitution, I might say, for the Physicians for a National Health Program and for Kentuckians for single-payer health care.
Garrett, when I was asked that question, I simply told the answer that this was a government-run health insurance program. And then the next question I was asked was whether this was going to be run by the federal government, the state government, a local government, or some sort of combination, the way it is in Canada, where the federal government provides the money, but the provinces do actually implement the healthcare system, and it's a little different in each province. So, how do you answer that question to the questioner back at Grand Rounds in December of 2019?
Well, the basic point, Mike, is that it's a government payment program. It's so the government simply pays the bills, and the delivery of health care in this country would remain private.
Yes.
So,
but which government does what, or or does it stay?
Well, the bill goes just like your friend Dr. Young in Hamilton, Ontario. He submits his bills to the Canadian Medicare, and Canadian Medicare pays him. And that's the way it would do
within the month. Yeah.
Yes.
I've
heard that same story.
Yes.
A good friend of ours, Jason Kelly, visited his friend in Canada, and his friend in Canada, Jason said, "How do you get paid?" And he turned to the assistant in the ICU and said, "Show him how we get paid." And she pulls out a little sheet, and then they get paid, and a check comes in the mail, and that's it.
Yeah, that's good. Again, the issue is there's a lot of lack of understanding of what these terms mean out in the world. Gene, you have a question?
Yeah. So essentially, you're proposing that all the insurance would be paid by the federal government, and the physicians and hospitals would submit their bills to the federal government.
Exactly.
Okay. And what will we do about the waste in healthcare? For example, we're the only country in the world that allows pharmaceuticals, doctors, and hospitals to advertise. How would we deal with those type of problems?
Well, for the pharmaceutical companies, the plan is to use monopsony buying power, the fact that there will be only one purchaser of drugs, to force the companies to have to deal and to sell them at a reasonable rate. So that's what's been denied us in this country. There were efforts to do that before, when they established Part D of the Medicare pharmaceutical plan, but they made sure they were in there lobbying the pharmaceutical companies to make sure that that wasn't in there, the ability to negotiate the rates down. So that's how that would be dealt with. Most of the waste in our system is caused by the effort to turn it into a profit-making business. All of that administrative cost is, all of these utilization reviews, all of these things, all the questioning of physicians' opinions relate to the effort of the companies to expand their profit and reduce their costs and reduce the care. So if we take that out, that is about 30% of the cost in this country, and we can reduce that, and of course use that money to expand care. And that's the plan. That's what's so good about it, is that it removes the administrative waste. And that's what didn't happen with the Affordable Care Act. It not only kept the administrative waste, it expanded it, because it did further attempts to regulate the insurance industry, building in, layer after layer of administrative work. The simplification of the plan is the strong point, and that's what allows it to be streamlined as a single payer plan and to save the money.
In the PHNP model, what services would be included? We learned when we talked with Ted Young that in the Canadian system, it covers the hospital and the physician services. There's some other little things here and there, but people for dental, hearing, and even for some prescriptions, they've got to either get they've got to get another additional insurance option to be able to get some of the medical services that are not hospital and physician, and maybe some pharmacy. I can't remember exactly what he said. So there is the need for dental and hearing and vision to have some other options. So what all's covered in the model of Medicare for all that you're proposing?
Our model, Mike, covers everything, and the payment for pharmaceuticals is a sticking point in Canada. That's the one area that I've heard some complaint about, in addition to some complaints about non-emergent wait times for certain surgeries. But that's the pharmaceuticals. But I can't see, Gene asked about advertising pharmaceuticals over television. I can't see that happening with the single payer plan. And as far as dental, hearing, and even long-term care are considered medically necessary services that would be included in our plan, the PNHP supported proposal.
Okay, thanks.
So I assume that the ACA, so-called Obamacare, would be eliminated and incorporated into the single payer plan?
That's right. Not eliminated, because if the Supreme Court threw it out and people lost their insurance, but eliminated in the sense that it would be replaced by something better. People would not lose their insurance. They would get better insurance, and everybody would be automatically included, cradle to grave, in a plan that where they paid no premiums and chose their own doctors and paid no co-pays, and actually could stop worrying about losing their insurance, as people do these days, as so many people are being laid off, and we have an employment-based system that endangers everyone.
Now, in most countries, and including England, which is a very socialized system, would they still have some private insurance if you can afford it? Would we under this system, would wealthy people be allowed to purchase private insurance?
No, if it duplicates a service that's available in the government funded program, that would not be permitted under the system. If it duplicates, but if it's I'm trying to think, cosmetic surgery, for example, could be done. But if it's heart surgery or even transplant, that would not be permitted.
You mean I couldn't get my nose fixed under Medicare for all, Garrett? I mean, no, if I wanted to have a nose with a point out the end.
Yeah, no, you did it. Yeah, but government's not going to pay for it.
All right, let's talk a little bit about reality, because I absolutely agree with everything you've said. One of the things I've learned after being a cancer surgeon for 40 years is that wishful thinking and happy talk are not reality always. Now, when the Affordable Care Act was established, we had a Democrat in the White House, and we had the Democratic control of both houses of Congress. They had to bargain away the public option, which at the time I thought would have been a good thing, certainly better than what we got. And they ended up having to give the for-profit insurance companies a medical loss ratio of 80%, while Medicare spends 2% on its administrative costs. Their for-profit insurance companies are able to get, 8 or 9 times that. So what I'm just trying to look down the road just for the sake of discussion. Suppose Biden wins and we take the Senate back. Do you really think that we're going to be able to put all those things in and ban for-profit health insurance companies?
Let me just differ a little with your premise. We were very active around single payer in 2009 and 2010, which was the year in which, they were working on the Affordable Care Act.
Yes.
And they did not start off and then negotiate away. The Democrats started with a plan that made the concessions before it got started. The person who wrote this bill, the Affordable Care Act, is named Liz Fowler. She comes from the insurance industry. And Max Baucus, the finance chair in the Senate, put her in charge of writing the bill. So it wasn't like the Democrats wanted single payer and then they negotiated away all the good things. So that's where what we have to do is persuade more of those people in the Congress that they cannot solve these problems. Here we are 10 years later, and we have the same problems, 30 million without insurance and another 70 million or so who can't afford their care, and a system that's busting at the seams because it costs double what the other countries pay. That reality has to be impressed upon Democrats and Republicans, that we need a solution and that there is no solution that includes the private insurance industry. So that's just my perspective on it.
Well, let me. We actually, in our last program, I told a story about a surgeon in Louisville who, after he had retired from practice, ran for office for state legislature, and Gene remembered that he was in the House, not in the Senate. And he gave a talk at the Louisville Surgical Society, and this speaks to your issue. I agree with you, but what he said a number of things. First thing he said was that making laws was like making sausage, and I'm not going to dwell on that. But the other thing he said was that the politicians, almost to a man, unless they have a medical background, really don't have any understanding of healthcare. They just simply don't understand it, and they rely heavily on lobbyists. And that's what I mean about the reality of getting something like this done with all the pieces that you and Garrett have mentioned, which I absolutely agree with. I just don't know how that's going to come out when you get into the sausage making process.
Well, we're getting into campaign finance reform and corruption in government, and I've written about that in the past. A system carefully shielded and supported by politicians who are rewarded with millions for their election campaign chests. In the first 6 months, the health industry lobby, which then outnumbered members of Congress 6-1, the industry lobby outnumbered the Congress 6-1, spent $1.4 million a day. $1.4 million a day to influence health reform legislation. No surprise that the healthcare law of 2010 was written for and by the health insurance companies. And in one of your recent good conversations, Gene and Mike, here's a point. There's a revolving door between Congress and the for-profit health industry. In 2003, Billy Townsend, a Louisiana congressman, and I remember this.
I remember
he
that
kept
too.
the Congress open until 3 o'clock in the morning, twisting arms. And after co-authoring the so-called Medicare Modernization Act, left Congress to become CEO of pharma at a salary of $2 million a year.
Yes, I remember that well. That's why I'm bringing this up. Those are the reality issues that,
Yeah.
like it or not, are out there. And I mean, Gene and I are here because we believe in this stuff.
Okay.
But at the same time, we have had to deal with reality. When you take a knife and open up somebody's belly, you deal with what's inside. It's not exactly how you would like to have had it. You have to just deal with the stuff that's there. And so I've got some real concerns about how this is going to end up. Hopefully it'll end up the way with all those pieces that you mentioned earlier. But that's a heavy load to hoe in this country with the type of Citizens United decisions that the Supreme Court are making.
Yeah.
One of the other issues is the for-profit health industry, particularly the for-profit insurance industry, is tending to get into the administration of health care rather than just being liable for it. For example, the Advantage plans, where they get paid so much by the federal government to run a system. And then also a lot of companies have gone to self-insurance, where the health insurance companies are administering the plan, but the health insurance company is not really liable for the plan. And more for-profit insurance companies are becoming very interested in this.
You're right, Gene. I mean, the big moneymaker now for the insurance industry is Medicare and Medicaid, and all of that's been contracted out through Medicare Advantage, so that their big money is coming by skimming off the public tax dollars. And that's what we have to do, is get them out of the mix so that the money can go for the care, because that's where Humana's big money is from the privatization of Medicare and these Medicare Advantage plans that they're selling. And I just saw the figures. We're paying $1,000 a year more for the Medicare Advantage plans than we are for the traditional Medicare. And they're making big bucks off of it, and somebody's getting rich, and the system needs an overhaul. For Medicare, we need to save Medicare. It's now projected that in 2024, it's close to the brink. And the Medicare for All will save Medicare and fund it properly and expand its benefits and benefit all the people who are currently under that program by making them eligible for more care.
Well, let me ask you a similar reality question about this process. Do you think it's probable that this would be something that would happen as a one-step, one-shot event, or do you think it is more likely that this would be some kind of an incremental step-by-step process that could take, I don't know, a couple of years? Who knows? Japan, who has a universal healthcare system, went through a process that took them 10 years to get to the point where they had basically universal healthcare, and similar to the principles and the details and the services that Garrett outlined initially.
I'll just jump in and ask for Kay's support. And that's Japan. Taiwan, on the other hand, made their change fairly rapidly, and it's been very successful. But those are the Taiwan experience is the one that I could cite, and they've been very successul.
Yeah, but this isn't Taiwan. That's the problem. Those countries are much more homogeneous than our country, and smaller.
Yeah.
Again, I'm not opposed to this. But
well,
I
I understand. I understand where you're coming from,
Yeah.
and it's sometimes it's, and and you've spoken before about Sisyphus pushing the rock up the hill, and that's exactly what we're doing, or the mountain
in some ways,
over and over again.
The incrementalism doesn't help; it hurts. We went to Medicare in one fell swoop. It took 10 months for the country to actually go into that other program. I know David Himmelstein, one of the physicians who wrote the PNHP plan, has a picture of Wile E. Coyote running up to the edge of this big ravine, and he has the cartoon says, you can't jump a ravine in 2 steps. And that's absolutely true. I mean, you have to remove the private insurance industry. That's what's making it cost so much. That's what's denying us care. That's what has to happen. That step is no big deal once you get the political movement in motion. And every single person in this country outside of the insurance industry has an interest in making that happen. We all have bodies, and we all have people we love who have bodies, and we all need the care. And so that means that there is potentially much more movement on our side than there is on the other. And we have to build the understanding and work to make it happen. They don't have an answer. Trump's still working. He hasn't yet put his plan out there that he's going to replace Obamacare with.
They don't have a plan. But again,
they don't have one.
Yeah, we're getting back to this issue of the guy walking down the street here with the mask on and and a backpack on his back. We understand these issues, but now Gene, out in Campbellsville in rural Kentucky, how much of an understanding you think those people that were on the boat dock before you did your before you did your sundown ski, water on one ski, think really have some sort of understanding of what we're talking about here?
Oh, I think very few people have understanding. As a matter of fact, I think most people in healthcare don't understand it. Yeah. That's one of the reasons there's been so much profit in the pharmaceutical industry and the health benefit managers and for-profit insurance, is because it made it so complicated that we don't understand it, and they're actually making money on that. I've tried to understand it, but I still don't completely understand the whole program, and neither does anyone, because it's in too many silos and there's too much secrecy.
Kate, can you talk about going to a single payer plan to address so many of the disparities in healthcare in the country, how that might address those disparities?
Well, that's true. I mean, one of the things we've seen in this pandemic is that the death rate from that disease is tragically double for the African American community. So we have a system that doesn't work for many, many people in this country. And single payer, while I don't think it doesn't solve every single problem, the first thing is that we have to get everybody covered. And in a situation where there are no financial barriers and where we have accessible care in every part of our city and our country, and that's what we have to have. I mean, it's like the foundation. The first step is you've got to get everybody covered. Right now, if you go onto Medicaid and then you get a new job and your income goes up, you'll get dropped from Medicaid if you go over the amount. We have a constant churn with people who become ineligible for their plan, or they get laid off at their job and they don't have that plan, and they buy an Obamacare plan and then they have another job and it changes the amount of the subsidy. It's so complex. Let's just get everybody covered first. That's what single payer does. in a system where patients and physicians are in charge of the decision making for what treatments need to happen. And that will take us a long way to making it a more equal system. For instance, we see in our city in Louisville, there are very few doctors and hospitals in the West End. They've all been moving to the East End. Everyone's building a new hospital out in the East End. Why? They're seeking the high-paying private insurance that is in those areas. Once we have every single patient will be paid for equally, there will be no need to run away from an area. We should be able to have facilities in every part of our city without a seeking of this private, because Medicaid pays lower. I mean, Medicaid's been a godsend, but it's not good enough. There are real indignities in having your doctor paid less for your care than the doctor is paid by private insurance. And that puts you at a disadvantage. And we'll do away with all of that inequality that comes from having this private insurance and then other people having a public insurance such as Medicare and Medicaid. It'll all be equal. And that's the beginning of having a just healthcare system where we can really concentrate on having a healthy society and a healthy community.
The current Medicare system pays for about 80% of the costs of hospital, physician, whatever it is, the services. Mm-hmm. And that leaves the patient with a 20% responsibility. How does that fit into the Medicare for all? Would that just cover everything, or would there be some component of whatever the costs are that would be the patient would be responsible for?
We're doing away with all of that no need for gap insurance, and no copays and deductibles. That's what we've got to remove. That's a part of what will give us a just system, because these economic barriers are keeping people from being able to get care. It would pay 100%. And of course, in the hospitals, there's a global budgeting system so that, the hospitals are supported by the system, but not able to rip off the system.
Garrett, how would physicians be treated? Would they still be in private practice, or would most of them be working for big systems or hospitals?
Whichever they would choose. That it allows for that, so that private practice can continue, but not as you pointed out, no for-profit direct payment. Your payment comes from the system, from the National Health Program.
We haven't talked about the funding issue. I went to I can't remember who's the guy from, I'm having Friedman, yeah, Gerald Friedman, yeah. I had a good talk with him at your house. That was very interesting. He was an interesting, funny guy. Now, that's a complicated process. And again, trying to get to the guy down at the dock working with Gene's boat, or somebody walking down the street here in front of the Abram building, getting to understand. We're a little short on time. We may have to come back and do this again, but can you kind of give us again, not for us so much as whoever's listening, a quick 5-minute summary of how this would be funded, the taxes, who, where, how, and because that's one of the issues that the opposition is going to bring up, is that you're going to get taxed to death.
I have a short summary from Charlie Casper, who's been studying this pretty carefully, and I can just very briefly state that we would save upwards of $600 billion annually by eliminating the health insurance companies. And then additional funding would come from payroll taxes levied on both employers and employees from 5 to 6%. And the maximum and minimum income levels would be negotiated for. And then a small tax on financial transactions such as stock and bond trades. And Friedman mentions generally about 0.5%. And that tax on unearned income. And the taxes would be progressive taxes. That is, depending on your income. So these are the basic categories. I've just read something about some plans that on taxing that Joe Biden has, which are pretty progressive as well. So any tax that is involved there will be proportional to your income.
Well, Garrett and Kay, thank you very much. Mark is waving the 5-minute message around, so I think he's going to cut us off soon to pull our microphones if we don't let him finish up here.
Well, I just had one final question for Kay. And Kay, how can folks learn more about Kentuckians for Single-Payer Healthcare and become involved in this movement?
Excuse me. Well, they can take a look at us on our website. It's kyhealthcare.org. Or they can email us at nursenpo@aol.com. We have meetings by internet on the first and third Thursdays of each month, and we'd like to invite them to be a part of that. And they can go to our website and get in touch with us, kyhealthcare.org. And we need them because, as Mike says, there's a big opposition out there, and so we got to get a lot more weight of people on our side.
Okay, Kay, and what about Facebook and maybe some other platforms?
Oh, we do have a Facebook page. Just search on Kentuckians for Single-Payer Healthcare. And we do Instagram, and we try to do Twitter. And we would urge everyone to help us to get out the word about our radio shows so that we can seek a broader audience as well.
Okay. Kay, and I just want to mention the sad news that you shared this past weekend, that Kevin Z's, who's been involved with Dr. Margaret Flowers with single payer, the movement for single payer and other movements, he unexpectedly passed. And I know Forward Radio listeners know Margaret and Kevin from their radio show, Clearing the Fog, that's heard here on Forward Radio. Any thoughts that you might have about Kevin's passing and
the whole
advocacy?
The whole movement has really lost a strong and vibrant advocate for single-payer healthcare. I remember when Margaret was here, she did some grand rounds as a physician and, did the public meeting, but we had a demonstration at the Humana building, and Kevin was there, carrying the banner and which said, Humana workers, we've got your back, and made the point about how legislation will have to provide for ongoing income for the workers in that industry. And Kevin was just a brilliant person and very active not only in the single payer movement but also in the peace and for justice for Latin American countries. So he will be deeply missed, and we are also sorry for the loss, and our hearts go out to Margaret because she loved him very, very much.
Yeah. Thanks, Kay. I did go up to a single payer camp a couple years ago and got to spend a few days with Margaret and Kevin, and was just amazed at their commitment and tireless efforts. I mean, in 3 days, we did a demonstration on the streets of DC. We did a demonstration in Senator Sanders' office to advocate for a stronger Medicare for All bill, and a demonstration out in DC one evening. And I don't see where they were on the clock all the time, and it's such a loss. And I'm with you. We just really want to send our condolences to Margaret about her loss. And just wrapping up, let me say that Single Payer Radio can be heard here on Forward Radio, WFMP 106.5, on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick us up on your radio during those times, we have a live stream that you can listen to us, or you could go to Forward Radio SoundCloud account. And on the Forward Radio Sound or on the website, you can click on the Programs tab and scroll down to Single Payer Radio and listen. You'll see all the shows that we've got on the air this year. And want to remind listeners, don't forget about Forward Radio Thursday, September the 17th on Give for Good Day. It's forwardradio.org. Kay, Garrett, thanks a million. Just really appreciate your insights and perspectives. Mike, Gene, thank you guys so much for making this happen.
Well, good to be here.
Good to be here.
Okay.
Thank you. Thank you.
For Single Payer Radio, I'm Mark McKinley. Thank you.